Hey guys, welcome back to the Foam Frat podcast. We're going to talk about the idea of having a max dose of your pressor and really the max dose of any medication, but specifically looking at pressors because every place that I've worked so far, they have a max dose. Once you get to this, you don't go up any higher. And I've reached out to my buddies, Shane O'Donnell from Foam Frat, Dan Rauh from Heavy Lies the Helmet, and Shad from Shad from the crawfish guy. So I ran into Shad when we had a little get together with the Boone brothers, and we did it out at Dan's place. And I got to know Shad, and he is a acute nurse practitioner, acute care nurse practitioner as well. You guys have some working relationship in the past, right? I thought it was at the fire department, but it sounds like you and Dan flew together. So we'll start off with you, Shad. Just tell us a little bit about yourself before we get into the discussion.
Sure. Yeah, I'll give you the short version. Been a paramedic for a pretty long time. Started working east side of Cincinnati as a fireman and went through nursing. And then eventually, with some experience, got into flight medicine and then off to grad school to Wright State. But yeah, I flew my last 8 years. Dan and I worked together at the University of Cincinnati.
That's awesome. Dan introduced you as the only guy that he's ever seen that has better hair than me. So I had really high expectations when you arrived at the get together.
It holds true.
Dan loves picking fights, man. He just
Well, awesome, Shad. Thanks for coming on, man. And Dan, everybody knows who you are, but just a quick little introduction because you worked in HEMS and now you work in the hospital, and you're just in the hospital now too, right?
Well, so right. I was a whacker of the fire for a long time, career fireman on the north side of Cincinnati, and had the misfortune of going back to nursing school through just a series of bad decisions. And then I was getting ready to retire, and I thought, man, I got to find something to do. So I went to nurse practitioner school, and I flew all those years in between. And then, so I flew, about 8 or 9 years at the University of Cincinnati as a nurse practitioner. And now I'm down just to one job, working in the ICU as an intensivist at a medium-sized hospital in central Indiana. And this will be my sort of announcement. I am the little rural town where I live has just changed EMS agencies to a fire department that's contracting to provide paramedic level service. So I'm thinking about volunteering a little bit of time to do some education for them and maybe make some runs from time to time on a paramedic chase vehicle. So just give
that's cool.
back to the community. Yeah. So so that's the deal with me, I guess.
Awesome. And Shane, just a quick little intro.
I'm Shane O'Donnell, flight paramedic in upstate New York, and I've been teaching with Foam Frat for probably 2 or 3 years at this point.
Awesome. All right, so let's get into it. So the concept of having a max dose, right? Typically, when you hear of a max dose, you think of when you get to that max, one of two things happens. Either you have a negative effect, right? You have too much of that drug on board, or you really don't get much of an effect at all. Would you guys agree with that, or would you throw in any other variable to that?
Yeah, I think that's the reason there's either a ceiling effect or a detrimental effect. Largely, I think max doses are designed for, it's like, spoiler alert, here comes a polarizing statement. I think max doses are kind of like merit badge medicine classes, ACLs, et cetera. It's designed to protect patients from inexperienced clinicians. So.
And when I think of, like you said, ceiling doses, you think of something like Toradol, where they came out and said, hey, you know what? Anything more than 10 milligrams isn't going to really cause or help any more with pain than before. And I think that obviously is helpful when you have that, because you're not just going to give more of something if it doesn't have a specific effect. And then you have drugs like nicardipine, where they tell us your max dose of nicardipine is 15. And, for me, I'm like, I don't know what the heck happens if you go over 15, because I've never done that before. But That's the max dose of that. But when it comes to pressors, they're almost a little bit of a different animal. And I was scrolling through X, formerly known as Twitter, and I saw a tweet by I Am Crit. And they made the comment, this is just your yearly reminder that the concept of max dose pressors is a fallacy. And I had a patient that was on, this ridiculous dose, 2 mics per kilo per minute or whatever of a pressor of Levofed. And then the next day they were like titrating them off of that. And so I thought that's really interesting because I've always been a believer of that same thing. And typically what I see is hospitals max out at 0.3 mics per kilo per minute. Like that's where the hospital says, yeah, you can't go any higher than that. Have you guys seen the same thing?
Yeah, but it's arbitrary. Like some hospitals, we do mics per minute usually around here. I don't know if it's geographic, but some places, you'll walk in and they'll say, oh, we're maxed out on norepinephrine and it's 40. And then you show up to the ICU with the receiving and that's half of their maximum dose. And definitely patient dependent. So I don't like the term max dose. I do like having embedded stopping points where you say, are we doing the right thing? And is this the right drug or should we be adding something? But I do think the maximum dose is just typically an arbitrary number that's made up, like Dan was saying, to protect the patient from somebody who doesn't know.
Yeah, I'm right there with Shane. I think some facilities you see a lot of in just looking online at certain protocols. Seems like a max dose or a stopping point is 30 mics per minute with norepi, but that's pretty still on the low end. I mean, you can see doses as high as 200. So, the thing with human beings is we all don't always react the same to drugs. We have different amount of receptors. If you think about like blood pressure medications, what a calcium channel blocker works for some person with high blood pressure, another person with that same high blood pressure has to have 3 different blood pressure medicines. So you can't just, put someone on norepi and say, all right, we get up to 30 and it doesn't work beyond that. And we don't have any literature to support that either, unless you count the rats, because it's all retrospective.
Yeah. And even in rats, there appeared to be a linear increase in some of the older studies with pressors as they titrated them up. And that's super interesting because that means, if you're thinking that when you give a pressor, the idea is for it to go in and saturate the receptors, that we may have way more receptors than we even are hitting with our small, sniff of Levofed. And I don't think that, we should routinely get super high with it. But I do think that there are situations, specifically like transporting an ECMO patient. For some reason, when you extend their circulation into a long tube, they like to get vasoplegic, and you have to start going up a little bit higher on the vasopressors. And so, Dan, I was curious with you at the hospital, do you guys have a max dose, a stop point? What is your general practice when you're finding that you're just turning up the Levofed and it doesn't seem to be working?
So yeah, we have a max dose, and we do not use weight-based norepinephrine at my shop. So it's just 30 mics is what the nurses all understand is the max dose. And when we go above that, you always get some consternation from the nurses. They'll wring their hands a little bit about, this is over the max. And I'm like, remember, the max is something that just lives in your head. The problem with max dose, I think, that oftentimes gets lost is that every person's max dose or ceiling dose for norepinephrine is going to be a little different based on what you alluded to, Tyler, the catecholamine receptors. If you're a young, reasonably healthy, 30-year-old female with pyelonephritis who's in septic shock, you can crank out a ton of catecholamines yourself, and you can probably nearly saturate your own catecholamine receptors just from turbocharged adrenal glands. But if you're a 150-year-old patient in the ICU who's uroseptic, you have tired adrenal glands, and you probably can't even come close to saturating your catecholamine receptors. So you need as much exogenous help as we can give you in the short run. But I think, and like you guys alluded to, I think the thing that bears consideration is if you have to get somebody up over, 70, 80, 90, 100 mics of norepi, that probably should at least be that moment where you check yourself a little bit and go, is this the right thing? Maybe I should put an ultrasound probe on them. Are they volume depleted? They have, do they needed some inotropic support? It's not a hard stop. It's just kind of check yourself, kind of like you do, if you find you're lining up multiple vials of medication to administer, you always want to check yourself and go, hold on. There's a reason they package this in vials, right? So if I need 4 vials, maybe I should X myself. Am I on the right track?
Did I carry the 2?
Yeah, that's right. That's right.
No, I love that point. I remember a specific call. I walked in and they had the patient on BiPAP and they said that they were very septic and they said they had maxed everything out. They had maxed out their epi, they had maxed out their levo, they had vaso going, they were given pushes of fennel. I mean, it was like everything. And they're like, we cannot get his blood pressure above. It was like 70 over 30, 70 over 40. And exactly what you said, Dan, like, it's like, okay, let's just, all right, I'm coming in with a fresh set of eyes. Let's throw a probe on the heart and just see what's going on, because this seems weird, right? I'm stacking up the mental vials right now of saying this seems weird. And we put the probe on the chest and the patient had right ventricular collapse during diastole and they had pericardial tamponade. And it's like, you're not going to outpress tamponade, right? I mean, you're making it even worse by doing that because you're increasing that afterload as well. And it was very interesting because I'm like, you could have kept going down that route, right? Like, oh, you know what? If there's no max dose, we gotta go up even higher on the levofed. And if you don't have a stop point where you go, hey, let's look at the heart, and hopefully you're not maxed out on every pressor before you say, hey, let's take a look at the heart. But you could see where you could go down that diagnostic momentum of they're really septic. Hey, you guys got methylene blue. You guys got angiotensin. This stuff isn't working. His pH is too low. Let's give 4 amps of bicarb, and then all of this stuff will start working. And I just thought that was really interesting. And I was like, that's okay. That's why there's stop points, or that's why there's max doses, because you could go down that tunnel. And I like 0.2-ish, 0.3 as going like, hey, maybe we should add on some vasopressin, even sooner in some cases. And how much volume have they had? These are all good, pertinent questions. But I was reading a post by Josh Farkas from PalmCrit. And he talked about this patient that he had that came in very septic, and they had maxed all their pressors out. And they said, hey, we're going to try to keep him alive long enough to get the family in here because nothing's working. His blood pressure was super low. Maps were tanking. And they said, we'll just turn up the pressors temporarily just to keep him alive for the family to come in. They went up to I think he said 80 mics a minute. And that was the magic bullet. And all of a sudden, the guy's blood pressure came up and he made a full recovery. And it's like, God, that's really interesting to me. And so I was curious, in the hospital, have you had patients that are just on ridiculously high doses, and then like the next day you're peeling them off?
Largely not. Mostly when we go to 4 pressors, we're going to comfort care and, we're circling the wagons, but occasionally, you'll have that situation. Something I think worth talking about is I think everybody that's flown has been in that situation where you're doing the RSI, you give all the drugs, and you're looking down at the patient and they keep looking up at you. Like their eyes never close. And you're like, hey, did you give all that ketamine?
Mm-hmm.
Yeah. Did you give the rock? Yeah. And you're like looking at him, you're like, so I'm like, sir? Yeah. And you're like, what in the actual blank is going on here?
Who started that IV?
Right. That's exactly right. And then you realize, oh, so it's the new sub-Q dosing of rocuronium, right? So that's a time to check those things as well, right? Make sure that the delivery device is right. I can take you back to a moment I had long ago when I was a baby nurse in an ER, and when we were using nitro all the time, and we were up titrating this guy's nitro who was having chest pain, and I had him up to like 200 mics of nitro, and he's still having pain. And so I called cardiology. I'm in the ER, and I said, hey, this guy's at 200 mics of nitro. He's still in pain. He's like, all right, I'll be in. The cardiologist, I got to tell you the name. He may even still be practicing. His name was Barney Beaver. I swear to you, that was the interventional cardiologist's name. Super nice guy. So I call Dr. Beaver and said, hey, this guy's still in pain. He's like, oh, yeah, I'll be right in. Call the team in. I walk around the side of the bed and immediately bust my ass and fall onto the floor where the nitro had come unplugged and is now discharging itself all over the floor. And I wiped out on the nitro drip on the floor. So just that checkpoint, right? Where you think about, is everything hooked up? Got any, what's going on here, right?
Yeah, I listened to an MCRIT podcast where Dr. Weingart talked about the art line actually being in a vein and them thinking, and like it was even pulsatile because the patient had some like venous congestion as well. And they thought the blood pressure was low and they just kept going and going and going up on the pressors and stuff. And I think somebody he mentioned, I can't remember the story, was like, we should take a non-invasive blood pressure. And it was like, 200s, like super high blood pressure, but the art line was actually placed in a vein. And I never forget that. I'm always like, okay, like if I'm going up on my pressors, it's like, okay, is this tamponade? Can I trust this actual blood pressure? It's not just one off reading, but it's been consistent. And then is it anything weird? Some, like you said, like IV is not in place, or sometimes you don't see the infiltration like you do on someone who's young when they're old. Like I had a patient one time, exactly what you said. We were given the RSI meds and I'm looking, there's no bubble or anything. You looked underneath the arm and it was all hanging out right here. Like it had all came down. And so even looking and evaluating that, but yeah, I think those are all really good things. And the other thing that comes up a lot when we're talking and doing like case reviews lately is the way that the non-invasive automatic blood pressure cuff takes that blood pressure, regardless of the machine. It measures the map, and I think everybody's kind of on the same page with that now, but it doesn't actually measure your systolic and diastolic. It'll measure the map because that's where the oscillations on the envelope are, the most clear. And then depending on the algorithm, it'll say, hey, if you go 50% over here, that's probably your systolic, and 70% over here is probably your diastolic. What's interesting, though, is when you look at your clinical decision-making after a call, and even though I know this and I teach this and I have classes on this in studio, I will always look at that systolic. That just has this like draw for me to look at that and be like, oh, it's dropping. Oh, it's going up. And I was looking at a clinician sent in like one of the little forms with all the blood pressures and stuff. And they're like, yeah, this patient was getting hypotensive and the systolic was dropping. But if you look, the map was like staying the same the entire time. The map wasn't changing at all. If anything, it got better towards the end. So I just throw that in there to say, make sure you are watching that map. If you're looking at your systolic and it's going up and down and moving around, as long as that map's staying relatively in the same area, that's going to be like the most accurate number that you can actually have. I know my buddy Brian Winchell down in Flight for Life, Texas, he somehow hacked his Zoll monitor to show the map as the big number and then the systolic and diastolic as the little number, just to make clinicians like remember that.
So I have two questions off of your point, Tyler.
Yeah.
Number one, you said, I think we're all pretty dialed into the Dynamap or the Zoll provides the map and then it calculates the systolic and the diastolic. I wish that were really true. I feel like a lot of people aren't dialed into that like they perhaps should be. I just had that talk last night in the ICU, and I got a lot of mystified looks from nurses that had no idea that it actually takes the map and then calculates the systolic and the diastolic off that. I think people aren't as informed about that as they should be. I'd be interested to hear what you guys think. And number two, this one's specifically for Shad. Shad, when you put in an art line, do you leave the damn blood pressure cuff on their arm? And if you do, why in the hell do you do that? And moreover, what do you do with that number then? Do you believe it when you like it? or how do you approach that? The two separate blood pressure numbers.
Leave it on the same arm. That's your
No, just
question?
in general. You leave a non-invasive cuff on someone who has an art line.
Oh, I think the nurses usually do. I go by if we got a good wave on the art line, that's what I pay attention to. If they're drastically different, then I start asking myself, is it truly in the artery, like Tyler talked about? And then you got to look at like things like cuff placement to make sure that it's properly placed, or you're not getting accurate cuff pressures. But I don't know. Once the art line's in, that's what I pay attention to most of the time.
You're just worried about billing that RVU, and then you've moved on to something else. Is that what you I just don't understand, and I'd be interested to hear what you guys think. We put an arterial line in ostensibly because either we don't believe the blood pressure cuff, the non-invasive, we don't think it's accurate, or we want something that we can really sink our teeth into. But then we leave the measurement device on that we didn't believe in the first place, and somehow consider that or contemplate what to do with that. What do you guys think?
Yeah, reassurance from the thing you didn't believe to begin with, right?
Right.
Yeah, I mean, I do like to have it on as a secondary point of evaluating not only like perfusion status, but like I said in the beginning, where the maps typically will correlate, but if for some reason they don't, and the non-invasive is, way higher than what the arterial line is, and I'm like, okay, what happened? Like this seems weird. The reverse, where I'm getting these really weird readings on the non-invasive, but the art line seems normal and I got a good waveform. That's something where it's like, yeah, okay, if the patient's complaining every 20 minutes or so when it takes a blood pressure, then I don't have a problem taking that off. But I'd like to at least at one point have a non-invasive pressure just to compare the two. What about you, Shane?
Just makes it feel so good when they look the same, doesn't it?
Yeah. Well, the maps correlate. I'm like, okay, cool. And maybe get an idea of are we clamping down really, really tight? What's going on here? Or is it in a vein, not in an artery? Do I need to re-zero it? Those
things happen in a hospital, and they certainly do in an aircraft too. When you start losing, like you said, if it is it not zeroed, or if you're not, in the right spot, you're getting too damped or something like that. So, you may have to readjust your what's the word I'm looking for? The
transducer.
The transducer to make sure it's in the right
axis.
spot. So, if your patient just went to a CAT scan or whatever and came back, and then all of a sudden they're not matching, and then you go in and the transducer's still laying down by their hip or something.
Yeah. I do think it's nice having the backup too. Like something happens, it gets positional, it gets wrapped up somewhere. You at least have a backup while you're troubleshooting the arterial line, especially if they're correlating before. I'm more likely to believe it. I do think most of these people should be on end tidal too, because that's a good surrogate for cardiac output. Certainly if they have a bunch of pulmonary physiology, that would alter things too. But I'm more comforted by a normal tensive blood pressure on the art line and an end tidal, 40.
What do you see as the downside, Dan?
I say you guys are victims of dogma. You're being attacked by dogma. I believe that if you have a good arterial waveform, then that is the end of the road. I think to utilize a non-invasive blood pressure at that point, we know what a joke non-invasive blood pressure really is, right? When all the confounders, right? People have vascular disease, venous insufficiency, cuff placement, wrong cuff size, all of those things. I would just argue that if we believe it, we believe it. Has anybody in the ICU ever been in a situation where we have somebody with a swan in and we don't believe the numbers? Like, I don't think that cardiac index is right. And then 5 minutes later, they arrest. If you don't believe the numbers, you shouldn't put the device in. And I don't see a reason to confound the decision-making with non-invasive blood pressure when you have an arterial line in. If the non-invasive blood pressure is good, then don't put in the art line. And you can save yourself, the hazards of percutaneous procedures.
Yeah, and that's the issue though, is like we're not putting an art line in, like maybe you guys were, but like if I pick up a patient and they have an art line, I didn't put it in. It was already in there. You're looking at an arterial line that has the transducer, you're putting them in a helicopter, you're trying to make sure that thing stays leveled with the right atrium. Like there's so many variables there that if for a couple minutes I'm trying to zero this or I'm trying to make sure I got it right, I still want to have that non-invasive on. And I don't see any harm in it. It doesn't confuse me at all. But I get your point. I understand it.
Like more confounders and a non-invasive blood pressure in a helicopter. Right.
I would say maybe equal for sure. Like, I mean, you're only going to be as good as where your transducer's placed, and
yeah, I've seen people panic when the transducer's like hanging down. And I mean, I've even seen it in the ICU. So
even the vibration sometimes on short final and taking off and stuff, I've seen that have effect on it. I don't know. I might have to disagree with you on that one, Dan.
Right.
But it wouldn't be a Foam Frat podcast with Dan if we didn't have something that we didn't.
That's right.
We didn't disagree on.
Dan, what's your threshold to put in an art line? Like, do you have a dose in your mind where you're like, this is a stopping point for like norepinephrine? You're like, if they reach 15, then they're getting an art line.
So my threshold is maybe less scientific than you might imagine. There's a lot of people, and I think Shad can probably vouch for this, that we start on vasopressors just to make the nursing staff happy, because they call you 1,000 times because the MAP 64, MAP 62, MAP 61, MAP 58, MAP 66. It's all over the place, and they're calling because there's all these metrics that we have to meet. So the reality of it is the person looks fine. They're sitting in bed and they're playing Parcheesi, but their MAP's 61. So we put them on, we show them the bottle of Levo, and their blood pressure comes up and they're off of it in 3 hours. Those people I don't put an art line in. But when I walk in a room and I'm like, oh, you look really sick, then you get an art line. So that's kind of my threshold. People that I think look really sick or I think are likely to become really sick, I put an art line in sooner rather than later, because rarely will you put in an art line and wish you didn't, but often you won't put in an art line and wish you did. So
on the topic of pressors, I wanted to bring up the idea, and I'm sure we've all heard this, like, oh, when your patient's pH reaches below blah, 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 drops below this, none of your pressors work. And you have to get your pH back up before those pressors work. And I've heard 6.9, I've heard 7, I've heard 7.1. I don't know of any good studies that really clearly define what number that is, but I think it's safe to say that when you become vinegar, that your pressors don't work as well. What do you guys think about that?
I find that these people are often at higher doses anyway, because whatever etiology they have that drove their pH to starting with 6, they're usually sick enough to be on the higher dose vasoactives. I've heard some theories, and I'm curious to see what you guys think, that vasopressin, because it's not dependent on catecholamines, has had better success. When I researched it, it was only in some cardiac arrest studies, and it was an incredibly limited number of patients. And the rest is kind of like theoretical around that. But I'm curious if you guys have heard that vasopressin is more effective in profound acidosis. But anecdotally, I've found that these people usually need the higher doses for it to become effective.
Yeah, I've heard the same thing. There's schools of dogma in the ICU. The cardiothoracic surgeons believe one thing, like that albumin works. They believe like that CBP has any value in our world. And they believe that vasopressors are very pH dependent. Other people, I think, maybe aren't as convinced. And Tyler, I think you're right. The evidence is all over the board. For every study you'll find that said, pH less than 7, you got to correct that pH. There's another study that says, we found that there's not really a strong correlation. So I don't really know what I believe. I know that I generally don't like to leave people underneath 7 for very long, just for a whole host of reasons. So I tend to be fixing it anyway. So it's kind of my take.
It's interesting because we use pH as a thermometer or some sort of gauge as to acidosis. But when you think about it, like I give the example, like I could go over to my thermostat right now and it could say 62 degrees. And I could be like, that's cold, and there could be a bunch of different things wrong, right? I could have the heat have gone out in my house. I could have a window open. I could have a door open. There's all of these things that could cause that to go down, right? So it's almost like this litmus, like it is a gauge pHs, but there's so many things that can change it. And when you look at what pH is actually measuring, it's just how often water, H2O, has one of its little hydrogens coming off of it and bonding to another one and forming, hydronium. And I'm like, that's it. That's what pH is. It's just how often water is dissociating in our body, in our plasma. And it's like, well, why would that change how pressors work? That seems weird. Like it's just how often water dissociates. But we also know that you could have a patient who is extremely acidotic from COPD, an asthma patient, and they tend to get over that acidosis pretty well once you're able to correct that, right? Or even patients who you use permissive hypercapnia because you're like, okay, as long as we can oxygenate this asthmatic or the COPD patient, it's fine. We'll just let the CO2s rise a little bit and maybe puts them to sleep a little bit. They get some of the narcosis from it. Whereas you have a patient who has metformin toxicity, acidosis, or DKA, and it's like, no, you got to treat this like right away. They don't tolerate it. So my theory, and this is just Tyler spitballing, but like it really is going to depend on the etiology of the acidosis as to if those pressors are going to have some sort of a diminishing effect. I've never seen anything about that written down anywhere. It's just, certain patients tolerate acidosis fine. They come driving into the hospital with 6.97. And then other patients look like hell at 7.2. And you're like, okay, it's hard to correlate a pH with a mortality, I guess you could say. And maybe there's a study that shows that. But with that, what is your guys' thoughts on that? Am I full of crap?
It's hard too because a lot of the disease processes can vary so much. Like a 98-year-old with urosepsis whose pH is 6.7 is probably overarching going to do much worse than 17-year-old DKA Timmy whose gas is 6.9, but he's done that 3 times this year too. So there's also this bias towards, one patient population just may do worse based off of extremes of age and like how quickly can the disease process be solved. An asthmatic who's acidotic is hopefully more often quickly resolved than somebody who has, a profound infection or something that's going to be longer lasting. Because asthma is hopefully a quickly resolved disease. Certainly there's patients on the extremes though.
Yeah, I think that's fair. There's intuitively, you have somebody with gut ischemia and they have a pH of 6.9. They're a lot sicker than, like Shane said, a DKA, a 25-year-old DKA who turns that pH around after 2 liters of hopefully not normal saline in the emergency department. But it seems like an art to be that way. I don't know if it's really true, but I think you make a compelling point, Tyler. Way more compelling than that ridiculous argument about the non-invasive blood pressure. The pH argument is very good. I like that. Anytime you bring in like covalent bonding and
here we go.
And stuff, I mean, that's going to be a winner.
He definitely had my attention on that one.
Yeah. Let's talk about steroids. What is your all's threshold to add steroids when you have somebody on high vasopressor requirements?
Oh man, I just don't know how much of the literature actually supports that really makes a huge difference. I don't have anything, as far as I know, in my guidelines telling us when to add a steroid on. And my personal practice, I don't typically find myself doing that, especially like in the transport setting, but I'd be curious from the hospital side.
Shadwick, being a big chest and SCCM guy.
I don't know. Right. I don't know when I finally decide it's time for steroids, if it's like a last ditch effort kind of thing. You know, I don't know. You tell me what you think. I mean,
Oh,
like
everybody.
I'm
Yeah,
topping
I mean,
out
I
of
do
this.
whatever you do, Dan.
Yeah.
So there have been a couple trials, right? There was the Corticus trial. That's an older trial. And then there was most recently one, and I can't remember the name of the damn trial because, cardiology gets all the cool names for the trials. Everybody else gets stuff. But it's like steroid or something. I'll come up with it, and you can put it in the show notes. But, what you're treating is adrenal insufficiency, right? And that comes in many forms, but and I think it's pretty innocuous. Maybe they need a little more insulin coverage for their sliding scale. But other than that, my general approach is if you get above one pressor, I'll at least either add on Solu-Cortef, 100 milligrams TID, or I'll at least consider it. Now if I put an ultra probe on their heart and they have a terrible EF, then I'll, fix their terrible EF. But if I don't really have an explanation, I'm like, why the heck? You're on max dose of norepi and your daggone blood pressure's not coming up. Why are you doing this? And you just came back from the OR, an hour and a half ago, then I would probably add on Solu-Cortef. So.
Do you do it based off the speed in which somebody's increased their pressors? Like if you walked into setting hospital X and they're like, we started at 10, but we're at 100 right now. Would you just walk in and give them some steroids right off the bat, knowing their heart's fine, everything else?
Yeah, I think it's not going to be harmful. Steroids largely are cheap. And if they have adrenal insufficiency, or if they have a known history of adrenal insufficiency, I think it's the most bang for your buck. It's like a lot of other things we do. It's all kind of cause and effect. So that's kind of my approach. And Tyler, I'd like to see you guys putting in art lines. I mean, that seems like compared to all the Shane, do you guys do art lines?
We don't.
No. I mean,
if you guys are putting needles in chests for pneumothorax, I would think that an art line would be well within your scope. Do you guys carry ultrasound on the aircraft where you're at?
Yeah, we both do.
Okay.
Yeah. So it's just like an IV, right? I mean,
yeah, we have. I mean, most of the stuff to do it is, we carry our own transducers just in case the facilities doesn't, connect with our monitor. So we have probably 90% of the stuff to do it. And I would love to see that as well. I don't know what type of liability comes with that as far as infection rates later on. I don't know. I've heard some people say that, EMS put this in, so if they get an infection, that's going to come back on the HEMS program that put it in. I feel like most people are probably taking it out and replacing it once they get to the hospital. But yeah, there's a lot of HEM services that do it. And obviously there's a reason they do it. So I'd like to see it as well. The other thing that I was going to bring up is the addition of calcium. If you think that the patient's ionized calcium is low, or if it is low, because you can activate that receptor, but what that receptor is doing is allowing an influx of calcium to go in and actually cause something to happen within the muscle. And so if your iCal is low and you're going high on your pressors, it would make sense that you may not get the most bang for your buck out of your pressors. Have you guys noticed that?
Yeah, I think it's reasonable. I mean, if you know what the iCal is, I would caution people that you be cautious. If you don't have central access, you probably want to go with gluconate over chloride, because nothing can destroy your peripheral tissue like an infusion of calcium chloride into the subcutaneous tissue. So, but as long as you account for that, I think it's certainly more than reasonable, especially if you're doing massive transfusion. There's lots of reasons to give it, I think.
Ionized calcium is the elemental calcium. That's the calcium that's floating around and is available to do work if you need it to do work. And obviously when you have a muscle that contracts, you don't need to put a ton of calcium inside of that cell for that to happen, because there is little stores of calcium. What is it? The sarcoplasmic reticulum or something like, yeah, reticulum. And so you only need a little bit, and then that will activate all of those. But calcium likes to bind to other things, and the stuff that's bound to lactate, to albumin, to different proteins is not available for work. So when you look at your calcium, you'll get a total calcium, and then you'll get an iCal. It's typically like a lowercase I and cal. I don't know. It just depends on how your lab does it. But the iCal is like what's actually available to work. And then the total, I mean, you could have a lot of this calcium bound to other things. And so, I've wondered when you get a patient who's septic and their lactate's increasing and you have calcium now binding to that lactate, if increasing or giving some calcium gluconate or calcium chloride would help you with your pressors as well. Shad, what do you think about that? I'm putting you on the spot.
I've definitely used calcium in hemorrhage. We've had some like bad GI cases come back to the ICU and given a lot of blood products, and I've given calcium for that. And most of the time they didn't have a central line. So like Dan said, I was using calcium gluconate. But like the steroids, I'm just kind of like, that's kind of on the back burner for me as far as in your typical septic patient. But
yeah. That makes sense. Shane, anything to add to that?
I've had like anecdotal experiences where you've shown up and somebody's been in profound shock states for a period of time, and they're like, we've given like 8 sticks of calcium, because every time we push it, it keeps working. So I do think there's a point of diminishing return where it's, it's like you're giving a stick of bicarb, and every time their blood pressure goes up, so you're just going to keep slamming with sticks of bicarb. And it's, after a certain point, you just say like, what are we doing, and should we be concentrating our efforts on something else after we've repleted the amount of calcium that we think we need to replete here?
Yeah, no, totally.
And remember, if you're given gluconate, you have to give 3 times as much because there's the elemental calcium, right? There is some pretty good evidence that says that just empirically given calcium during cardiac arrest is not helpful.
Yeah, I've seen that, and bicarb.
Right.
Yeah.
But you always hear people say, well, what's it going to hurt? I'm like, what the hell? Just give them a dose of Pitocin. What's that? Drugs.
Hey, wait, isn't that what you just said about the steroids a few minutes ago?
I didn't want to say nothing.
You have physiology for it, Shad. Yeah. Now you have an opinion on it. You didn't have an opinion before. Tyler, I got one other pearl here.
No, let's hear it, man. Let's hear it.
All right. I just want to make sure everybody's aware, when you are given epi or you have someone on an epi drip, that drives up the lactate, right? The lactate number gets larger on people with epi. So
just stop checking the lactate if the patient's getting better.
Check the neutrophil to lymphocyte ratio, right?
Yeah. Stop. Yes. Serial lactates are not a thing, and serial ammonia levels are not a thing. Stop making them a thing. They're not a thing.
Yeah, and that's because when you give epi, you increase the rate of glycolysis like super quick. And so you're spitting out all this pyruvate, and it can't all go into the Krebs cycle at once, and so it gets converted to lactate. So it's a different reason than when somebody is in an anaerobic state and they start elevating their lactate. And I think that's important.
Very similar as to why beta agonists we use for nebulizers do the same thing. Because of the beta stimulation.
Mm-hmm. All right, we said words like sarcoplasmic reticulum. What did
you?
No, and what did Dan say? Dan just said so. Oh yeah, he came up with reticulum. I said sarcoplasmic. So at Scrabble, we both get a point for that.
That's right. That's right.
Dan, before we close out, I know the Critical Care Transport Academy is accepting applications right now. You want to talk a little bit about that?
Yeah. Thanks, man. Through AIMS, which is sort of our sponsoring agency, we have the Critical Care Transport Academy. It's for those of you who aspire to a career in flight medicine. We provide you essentially free, with the exception of covering your expenses to come to a conference. What I believe to be some pretty high-level education on a monthly basis, where you get a bunch of material that you review, and then a case study, and then you do live or virtual meetups with the other mentors who all come from high-level flight programs to go over your responses to those case studies. And then we have an in-person conference that I think will well prepare you for a career in flight medicine. You should have 3 years as a nurse or a paramedic, and people that apply to this program, I'd encourage you to be ready to go to work, because we put a lot of effort into providing you with cutting edge information, and we expect you to match our efforts. So I think I believe in it. I do it for free, which is evidence of how much I believe in it. And if you have questions, you can certainly send me an email. You can go to the AIMS webpage. There are lots of, it's on social media everywhere. If it made Foam Frat's social media feed, you know it's something.
No, it is good. It is really good, man. We love all of the groups that are trying to help people prepare for a career in critical care. And even if you don't plan on flying, or you don't want to fly, but you want to get better at critical care, I still recommend checking it out, because they got some top-notch instructors. And it's, I believe all the instructors are doing this like voluntarily, right? They're not. So guys like Dan and a bunch of other really good people. Is Mike Boone still doing it?
Mike Boone is not. He stepped back only because, with Crash and Learn, he's been super busy. But there are, just to run through the mentors and people you probably all know, Nick Voles, Matt Benson, Kim Morgan, Shane Turner. Now I've pressured myself to remember everybody.
Is Adam Tresidor doing it?
Adam also stepped back because he's having babies left and right out there in Oregon. Or not Oregon, in Idaho.
I'm 2 for 2 with naming people that aren't doing it.
Oh, well.
I'll just shut up and let you name them.
The reticulum.
Yeah, right. So let me say this. If you want to know who the mentors are, go to the AIMS webpage. There are little pictures of all of us there. It's just been a fantastically rewarding thing to see people really advance their practice. There's a lot of good things now. When I started flying, there were very few quality continuing education avenues. And now stuff like Foam Frat, Tyler's been incredibly helpful to us through the Critical Care Transport Academy. Essentially, just gives you the keys to the business. Says, hey, whatever you need to help your people, I'll do it. So I just can't say enough good things about really, Eric Bauer at Flybridge has been really helpful with our CME process. Lots of people have been involved. I'd be remiss to try to name them all, but and anybody that I've called, and asked to do a talk or whatever, have all been very willing to help. So do yourself a favor and check it out, and reach out to us with any questions.
Yeah, I'll put a link to it in the notes of this podcast as well. And Shad, do you have a blog or anything? Anything you want to
plug?
No, just on Twitter X. So
you're on Twitter. X. What's your handle?
S Ruby 345, which was my old fire department badge number.
S Ruby 345. Cool. All right, boys. Well, this was fun. I'm gonna go try to start editing out this podcast and get rid of everything Dan said about the non-invasive blood pressure.
I was in the ICU last night, Tyler, and one of the nurses came through and said, hey, I was listening to one of your podcast deals. I'm like, oh, is that right? Said, yeah. I can't believe you told that guy that was the craziest thing you'd ever heard. They were talking about our RSI thing.
Yeah.
I said, oh, that's Tyler. If there's one person that can take it and give it, it's Tyler. There's no question.
What were we talking about? What was the topic?
Oh, you were talking about I think the name of the white paper will be entitled "The Routine Use of IM Ketamine in RSI."
Oh, yeah.
Hey, don't forget to show him that Pressor book you got too.
Oh yeah, Shane, you got that Pressor book on you.
Yeah. So one last shout out. This is a new book. I want to say it came out like 2 months ago. It's the Vasopressors and Inotropic Handbook.
It's backwards.
Like 150 pages, and it's fantastic. It cites a bunch of literature in there, talks about the vasoactives we see a ton, and the ones that we don't. I think the most interesting fact is the highest reported norepinephrine dose in the literature is 30 mics per kilo per minute.
Nice. Was that on a human?
Yeah, for a period of time.
Poor little sad rat.
It was a blast injury, and she was on that dose for 4.5 hours and survived neurologically intact to baseline. So
interesting.
Who wrote that book, Shane?
Eddie Gutierrez, I think is the last name.
Yeah, I think you're right. Gutierrez,
yeah. But it's been he has a podcast too, but it's a fantastic book. It came out.
What's he say about steroids, Shane?
Yeah, that was on page 150, and that's where I stopped. So
he said there was only 150 pages.
Never heard.
It was on the back, I think.
Awesome. All right, guys, have a great night.
All right, see you, fellas.
See ya.
Good seeing y'all.